All right, so we're going to be talking about chest pain today. The chest pain that we're going to be talking about is going to be ischemic in nature, so ischemic chest pain. And I will be using a lot of acronyms throughout this, and this will be the talk for basically 8, 12, 2016 for our little board review course, predominantly covering chest pain as we're kind of in the cardio section. So, what is chest pain? I kind of divide this up into three things, and those three things are basically your diamond criteria. So, our diamond criteria. And that is basically number one is just that it's chest pain. Number two is that the chest pain came on with exertion or emotion, and that the chest pain decreases or is relieved with rest or nitro. So rest or nitro decreases the pain. The pain came on with exertion or emotion, and that you have chest pain. If you have 3 out of 3 of these, this is called typical chest pain. If you have 2 out of 3, it is atypical. And if you have 1 out of 3, this is non-cardiac. So cardiac, non-cardiac chest pain. And this would be the diamond criteria. What is the most common cause? Most common cause of non-cardiac chest pain. And usually it's something GI related, whether that be GERD, peptic ulcer disease, non-ulcerative dyspepsia, those type of things. Now that we know what kind of chest pain is for this scenario, we'll talk about what is not chest pain. So what's not chest pain? And the three things that we'll list here are about 95%. This is about sensitive and specific for non-cardiac chest pain, especially for a board exam. For a board exam, if they tell you these things, you can take it to the bank that it is not cardiac chest pain. In real life, everyone needs a full workup for chest pain. But these things are, number one would just be positional. And something that's positional is to be kind of pericarditis. Something else would be pleuritic. And if it's pleuritic, you're kind of thinking about pleurisy. And then our number 3 down here would be tender. And this would be, your costochondritis. So costochondritis would be the tender. So positional, pleuritic, or tender. You don't need to be thinking about chest pain as kind of or cardiac chest pain is the cause. Usually it's a non-cardiac source. So kind of going from there, now that we know what chest pain is and what chest pain is not, we need to think about kind of the risk factors and the risk equivalents when we kind of go through chest pain. When we think about risk factors, I like to think about metabolic syndrome. And your metabolic syndrome stuff, it consists of basically 4 main things. The first one being diabetes, second one being hypertension, third one being hyperlipidemia, and your last one being obesity. So basically, if you have these 4 things, these are all risk factors for basically coronary artery disease and those type of things. And this would be your metabolic syndrome, would be this kind of 4 group of things. Your risk equivalents, this would be your diabetes, your chronic kidney disease, your peripheral vascular disease, and your abdominal aortic aneurysms. So these would be your risk equivalents, and diabetes is in both right here. And so what does this mean? These are equal to coronary artery disease. So if you see them in a stem of a question, you need to be thinking about coronary artery disease as something that we need to be aware of. The last thing that we kind of have over here in this risk factors, risk equivalents, it's just age and family, basically family history. So for age, if you're a male and you're if you're a male and greater than 45, it gives you a risk factor. Or if you're a female and you're greater than 55, it gives you a risk factor. And for your family history, remember we're looking for premature coronary artery disease in this scenario, or early heart disease. And it's basically a male that had heart disease or coronary artery disease before 55, a male less than 55, or a female less than 65. So female less than 65, male less than 55, first degree family member. So first degree family member actually gives you a risk factor for coronary artery disease. So we have risk factors or risk equivalents, and then kind of age, family stuff. Remember, our risk factors are going to be kind of broken into your metabolic syndrome, diabetes, hypertension, hyperlipidemia, obesity. Your risk equivalents are going to be your diabetes, chronic kidney disease, peripheral vascular disease, and your abdominal aortic aneurysms. For the age and family history, for family history, it's a first degree relative. First degree, that's the big one there. So that's mom, dad, brothers and sisters. First degree relative with a male less than 55 or a female less than 65. And then for the age itself of the patient, it is a male less than 45 or a male greater than 45. I apologize. Male greater than 45 or female greater than 55. We give you a risk factor. So now that we've kind of talked about what it is, what it isn't, and risk factors, we want to kind of think about what we want to do about it. So what do we want to do? And what do you want to do first? If you had to pick one thing to do first, what would you want to do? So you have someone that comes in with chest pain, plus maybe some ECG changes. Or you have someone that comes in with chest pain, plus known coronary artery disease, or coronary artery disease risk equivalent that we just kind of talked about up there, which is your diabetes, your peripheral vascular disease, abdominal aortic aneurysms, your CKD. Or what if you have someone that comes in with a STEMI? Or you have someone that comes in with a non-STEMI. What is the first thing you want to do? And in all of these scenarios, the first thing we want to do is give aspirin. So remember, that's going to be 325. Sorry, guys, 325 chewed, and give it immediately. So that is the first thing we want to do for all of these scenarios. STEMI, non-STEMI, chest pain with known coronary artery disease, or chest pain with EKG changes. And remember, these EKG changes are just from baseline. It doesn't have to be ST depressions, doesn't have to be ST elevations, doesn't have to be T-wave inversions, just a change from baseline. You need to, with associated chest pain, you need to go ahead and give them aspirin. So what is the first test we want to do for someone that comes in with chest pain? That kind of makes sense. We kind of intuitively know the first test you want to do for anybody with chest pain is your ECG. That's going to be the first test you do. The question that you'll get asked, at least kind of in relation to step 2, is what is the first or the next best step in management of the patient? So they're going to ask you the next best step in management, and you'll have aspirin, you'll have EKG or ECG, you'll have chest X-ray, and you'll have maybe oxygen, or you might have nitro or morphine, all those down here. And it's going to be someone that comes in with chest pain, and they're also going to have known coronary artery disease. So you have chest pain and known coronary artery disease, and what is the next best step in management? Remember, management can be a test or a treatment, so it can be a test or a treatment when you talk about your management questions. And in this case, it's aspirin. Aspirin is the best because it decreases mortality. The nitrogen, oxygen, and morphine. Oxygen, there's one study that said oxygen was bad. In that study, the oxygen was given at like 10 liters a minute. That's just blowing your face off, especially if you just need a little bit. So 2 liters, probably never a bad thing. But it doesn't actually decrease mortality here. I mean, if you're hypoxic, it would decrease mortality, but most of your patients that are coming in with chest pain aren't acutely hypoxic. So in the best scenario here, aspirin is what you do first. ECG is going to be your first test. Aspirin is going to be your first treatment. If you're asked what is the first or next or best step in management of this patient with chest pain and known coronary artery disease or coronary artery disease risk equivalent, you want to give them aspirin first. That's going to be the first thing you do. Then kind of going from there, we want to talk about some of our acute coronary syndromes, but just divide it up into basically your STEMI and your non-STEMI. Non-STEMI. And these will kind of be the 2 we talk about first. So for STEMI and non-STEMI, when I think about these, I like to think about what are the kind of the steps, the progressions that you go through, and what do we need to know for each. And I put the numbers 4 and 6 out here to know how many I need to know for each of these. So the first thing for both of them is aspirin, but we're going to do STEMI first because I feel like it's a little easier. So number 1 is just going to be give aspirin. And like we said earlier, just above, aspirin is kind of the way to go. First thing you do. So number 2 in this case is going to be PCI or angioplasty or angiography or taken to the cath lab, or thrombolytics. And anyway, probably 100% of these words are misspelled, but you hear what I'm saying. So PCI or thrombolytics. The next thing we want to kind of think about are kind of our symptom control, which is going to be our morphine, our oxygen, and our nitro. And then the last thing we want to think about is what we send them out on discharge, which they need to be on daily aspirin, a beta blocker, an ACE inhibitor, and a statin. And these are the kind of the things that they need to be on when they're leaving the hospital. Um, Going back up here to number 2, when we talk about PCI and thrombolytics, remember if we're going to do PCI, it needs to be, you need to have a door to balloon time of less than 90 minutes. So if you're at a PCI hospital, which a hospital that can do primary percutaneous coronary intervention, it needs to be done in less than 90 minutes, but this is only 20 to 25% of hospitals in the United States. So if you're at a hospital that can do it, you need to do it in less than 90 minutes. If you're not at a hospital that can do primary PCI, you need to think about thrombolytics. And your first kind of number one, this needs to be basically how far are you from the hospital that can do PCI. So are you greater than 120 minutes or 2 hours from a hospital that can do PCI? And if you are, you need to give thrombolytics. And if you're going to give thrombolytics, it needs to be in less than 30 minutes. So if you give thrombolytics, it needs to be in less than 30 minutes. And you give it if you're at a hospital that's greater than 120 minutes from somewhere that can do this. After you give the thrombolytics, you still need to ship them to a place that can do PCI because they will need angiography as well. So, like from the top again, aspirin is the first thing we're going to do. Then we're going to think about our PCI and our thrombolytics. Then we have our symptom control, which is our morphine or oxygen or nitro. And then what we give on discharge, which is aspirin, beta blocker, ACE inhibitor, and statin. And remember, thrombolytics are done in less than 30 minutes, and our PCI is less than 90 minutes. So now we're going to kind of bump over here to NSTEMI, and I'll just kind of scroll on down. So when we think about NSTEMI, we want to think about kind of the things that we need to do for it, and there's 6 main things kind of that are involved. The first one that we need to think about is, or the first 2 are very time sensitive and need to happen immediately when we think about treatment of an NSTEMI. And like I said, as always, aspirin is number 1, but we're going to combine this with our clopidogrel. Okay, so we're going to combine it with clopidogrel. So aspirin plus clopidogrel, that's going to be step number 1. Step number 2 is going to be our heparin or our low molecular weight heparin or enoxaparin. So that's going to be step number 2. So this is time sensitive. These things need to happen quickly in the treatment of NSTEMI. So aspirin plus clopidogrel or heparin or low molecular weight heparin or enoxaparin. Of note, even for STEMI up here, if you're allergic to aspirin, you give clopidogrel for STEMI. If you're not allergic to aspirin, you give aspirin and clopidogrel for non-STEMI. So then we kind of get into stuff that is not as time sensitive, but needs to happen in about 24 hours is what we need to think about. And these are 2 main things, and this is our glycoprotein 2B3A inhibitors as well as PCI. So these things need to happen in about 24 hours, and this needs to be done. Primary percutaneous coronary intervention needs to happen in about 24 hours from the time of the NSTEMI, unless our chest pain is completely resolved, or we decided it wasn't, or the patient is not a candidate, that type of thing. And this needs the glycoprotein 2B3A inhibitors, one of them, needs to be given before PCI. The last 2 things down here are basically stuff we use for symptom control, which are morphine or oxygen or nitro, and the stuff they need to go home on when they get discharged, which is our aspirin, our beta blockers, our ACE inhibitors, and our statins. So this is kind of the treatment protocol for NSTEMI. Now, kind of going back up to here, this 3 and 4. So there are many different things that can speed this up, and one of them is basically non-resolving chest pain. And this is the big one that you're tested on for board exams, is the non-resolving chest pain in someone that comes in with an NSTEMI. And what do you need to do? You've already put them on heparin or low molecular weight heparin. You've already given your aspirin, your clopidogrel, and they're still having chest pain. And you can't make it go away, so it's still there. What you need to do is first you need to give the glycoprotein 2B3A inhibitor, and then you need to take them to PCI now. So as opposed to waiting the 24 hours. And what is a non-resolving chest pain? That's chest pain that is still present after we've given the morphine, the oxygen, and the nitro. We can't get it down because their blood pressure is too high. They're still diaphoretic. They're still nauseated for whatever reason. We can't get their chest pain to go away. We probably need to take them to PCI earlier or sooner rather than later. And in that scenario, we need to give one of the glycoprotein 2B3A inhibitors. And just for FYI, what are the glycoprotein 2B3A inhibitors? That's abciximab, and I can't spell it, but there's an X and a MAB in it. And that's tirofiban, and that's eptifibatide. And this is going to be my eptifibatide. So abciximab, tirofiban, and eptifibatide. So those are going to be the medicines that you can use for your glycoprotein 2B3A inhibitors. That'll pretty much cover most of the stuff for the NSTEMI. The things to note on this is that kind of management of NSTEMIs is very cardiologist, cardiothoracic surgeon, and also just what our kind of standard protocols are at a hospital on what you give. Some even bodies say don't give this because they could be going to surgery, and if they go to surgery, you're going to delay surgery. Same thing kind of goes here. So you can kind of run into people that have different thought processes on it, and whenever you look at the American Heart Association and kind of how to do it, they kind of suggest the aspirin plus clopidogrel load, and then following the treatment algorithm that we have here, in best case scenario. But they say it's reasonable to do a few other things. But for step 2, step 3 board exam, this will be kind of all you need to know. Now we kind of get into the last little part of our talk, and I just kind of want to talk about this kind of platelet aggregation cascade, so we know where some of these medicines work. The first one, since we've kind of been talking about it the most, is the glycoprotein 2B3A inhibitor, which is your abciximab, your tirofiban, and your eptifibatide. So if we have a platelet here, this will be our platelet, and we have our this will be our glycoprotein 2B3A inhibitor right here, or 3A receptor, sorry. This is going to be the glycoprotein 2B3A receptor. What does this receptor do? And this receptor binds to fibrinogen and actually connects to another platelet. So that is going to be the kind of the job of that receptor. And this is blocked by the medicines that we talked about a minute ago, the glycoprotein 2B3A inhibitors. So what leads to the expression, or that increases the expression of the glycoprotein 2B3A receptors? And that's going to be activation through your ADP receptor. So your ADP receptor, whenever it gets activated, it will lead to increased expression of your glycoprotein 2B3A receptors. So what leads to a expression of your glycoprotein? What leads to expression of your ADP receptor? So this is going to be via activation of the glycoprotein 1B receptor. And remember, glycoprotein 1B receptor, if we have our vascular endothelium up here, it binds to the injured part, or the plaque that's ruptured. It binds to von Willebrand's factor. So we have von Willebrand's factor up here, which is bound to by the glycoprotein 1B receptor. It's going to activate the kind of the COX pathway within the cell, which is going to lead to increased thromboxane A2. And remember, thromboxane A2 is going to increase platelet aggregation, cause vasoconstriction of the blood vessel. And that aspirin is what inhibits COX. And remember, it is irreversible inhibition of COX, the COX pathway. And it is platelet specific. It happens a little bit more in platelets than it does kind of anywhere else. So the glycoprotein 1B receptor is going to get bound to the COX pathway, and increased thromboxane A2 are going to be excreted, which are going to cause increased platelet aggregation and vasoconstriction. That's also going to lead to increased expression of our ADP receptor. Your ADP receptor is going to be bound by ADP, which is also released by the platelet itself. And this is actually blocked by our clopidogrel. Clopidogrel blocks this. And this this activation of the ADP receptor is going to lead to increased expression of our glycoprotein 2B3A receptor, and that's going to lead to increased binding of platelets to other platelets and kind of precipitate this whole pathway. So, and then just kind of to cover a few other things, just because it's always good to know. Remember, in our vascular endothelium up here, we have our Weber-Palade bodies, and within our Weber-Palade bodies are our von Willebrand factor. And in the Weber-Palade bodies, it's a large multimer of von Willebrand factor. So multiple of the von Willebrand factors kind of all stuck together, big multimer. And that is released by the Weber-Palade bodies whenever you have vascular endothelial injury. So this is going to be cleaved into the monomers that we see here. So this is going to be our von Willebrand factor monomer that's going to bind to the vascular endothelium. So, and what does that cleaving? That's going to be our ADAMPS. I call it ADAMPS. So Adams TS, I guess it's TS 13, which is just a metalloprotease. It just cleaves the von Willebrand factor into the von Willebrand factor monomers. If we have a deficiency in ADAMTS13, it's not present. This is TTP. So TTP is a deficiency in ADAMTS13. And remember, plasma pheresis or exchange is how we treat TTP. So, like we said, we have the von Willebrand factor in the Weibel-Palade bodies. It's released as a multimer. It's cleaved by ADAMTS13 into the monomers. And if you have a deficiency in ADAMTS13, that's TTP. The monomers will bind to the vascular endothelium, and they are bound by glycoprotein 1b. If we have a deficiency in glycoprotein 1b, what's that called? That's called Bernard-Souliers. So Bernard-Souliers is deficiency in glycoprotein 1b. Activation of glycoprotein 1b leads to activation of the COX pathway, which increases thromboxane A2, leading to vasoconstriction and increased platelet aggregation. The COX pathway is completely and more specifically as well as irreversibly blocked by aspirin, which that's the first thing we're going to remember. And this is all going to lead to increased expression of our ADP receptors. Our ADP receptors are bound by ADP, which is also released by the platelet itself, and this receptor is blocked by clopidogrel. Increased expression and activation of our ADP receptor is going to lead to increased expression and activation of our glycoprotein 2b3a receptor, which is also bound by other platelets. This is blocked by the medicines that we talked about earlier, the glycoprotein 2b3a receptor blockers, which are your abciximab, your tirofiban, and your eptifibatide. So these medicines. This is also if we have a deficiency in your glycoprotein 2b3a receptor. We have a deficiency in this. This is Glanzmann's. And if you have a antibody against glycoprotein 2b3a receptor, that is called ITP. So the antibody to glycoprotein 2b3a is ITP. A deficiency in the glycoprotein 2b3a is your Glanzmann's, and it is blocked by the glycoprotein 2b3a receptors, which are your abciximab, tirofiban, and eptifibatide. And that will do us for this talk. Thank you, and if you have any questions, just let me know.